My name is Leia Reyes and I am an EMT intern at First Response Training Group. I will be talking to you about respiratory concepts and skills. Prior to this, I will ensure scene safety and proper PPE. I will have gloves on since I am dealing with medications and possible secretions and or exposure to bodily fluids. First, I will be talking to you about administering respiratory medications. These can be given through meter dose inhaler, also called MDI, and an SVM, also known as a small volume nebulizer. This is an example of such. So this actually can convert liquid medication into a fine mist. These kind of devices deliver atomized medications and are breathed in through the lungs and delivered into the alveoli. So first you want to obtain med-controlled direction and utilize local protocols. You want to confirm it's the correct medication and check any expiration dates. Confirm the patient has no allergies to this specific medication. You want to connect the tubing to the nebulizer machine, and you want to run the oxygen at 6 to 8 liters a minute. So essentially the medication will be delivered through here. You'll close this, ensure that it's nice and sealed, and the tubing will be connected, and through prayer slips with the full seal, patient will breathe normally into the nebulizer. So you'll let the patient tolerate the medication for a couple minutes. Usually it lasts around 5 minutes, and you want to reassess your patient afterwards. Next, we're going to be talking about assessing a patent airway. So you want to look, is there any signs of airway obstruction? Because this can result in a partial or complete blockage of air movement going in and out of the lungs. So essentially a patient who is responsive, such as one who is crying or yelling or talking, they will have an open patent airway. But sometimes you run across patients who are unresponsive, have a decreased level of consciousness. You want to assess patency immediately. You can utilize maneuvers such as the head tilt chin lift and the jaw thrust maneuver if you need to consider C-spine or any neck injuries to assess airway, clearing airway, and reposition and evaluate the patency of the airway. In addition, suctioning, especially if they have any secretions or blood from the airway to help clear, and then removing the obvious foreign body as well. Next, we'll be talking about suctioning. So you have different types of devices, such as a hand-operated unit, a fixed unit, and a portable unit. A hand-operated unit is a very small handheld device. A fixed unit is one that's attached to, let's say, a wall or mounted into the wall or into a truck. And then you have a portable unit, one that you can carry essentially in a bag. So you want to gather your supplies first. You need a rigid suction tip. This is an example of one. It's called a Yankauer. This is also called a tonsil tip. This is best for infants and children. Then you can also utilize a non-rigid plastic catheter, such as a French or whistle tip is what they call it. And these are utilized for stoma, nose suctioning, and through clenched teeth. In addition, you need disposable collection bottles and canisters and water for rinsing. So when you set up your suction, you want to inspect your equipment and your battery and make sure your suction device is working as well. You want to turn it on and make sure it is to about 300 millimeters of mercury. And you want to measure the catheter, such as this, to the correct depth. So you want to assess the patient, look at the patient's mouth, assess from the corner of the mouth to the angle of the jaw to assess how deep you want to suction. And you can hyperoxygenate the patient prior to suctioning, because suctioning actually removes oxygen as you're suctioning. So you want to suction in a circular motion. I don't have a small plastic catheter, but I will utilize movement as this tube, which actually connects to the Yankauer. So you want to, again, hyperoxygenate, and then you want to suction in a circular motion on the way out. You never want to apply suction going in, always as you're withdrawing. For adults, you want to suction no more than 15 seconds. For children, no more than 10. And for infants, no more than 5 seconds. So now we'll be talking about assessing effective breathing and advocacy breathing. So you want to look at the patient's chest and you want to assess the respiratory rate. Essentially, you want about 12 to 20 breaths per minute. You want to look at the rhythm. Is the rhythm regular or irregular? You want to look at the quality of breathing. Is it normal breathing? Is there any signs of obstruction or any difficulty? So normal breathing is almost silent. Sign of abnormal or maybe indicates airway obstruction could be a sound of snoring. Also, you want to look at the depth of breathing. At this point, you can also take breath sounds. You have different breath sounds such as wheezing, crackles, rhonchi, rales, and sometimes even diminished. So now we can talk about, now that we've talked about normal breathing, we'll talk about asthma exacerbation and what happens in an asthma exacerbation. So this is common in both kids and adults, most often kids, and this is actually a common childhood illness. So in pediatrics, you want to assess for any retractions. You want to look above the sternum and between the ribs, and signs, symptoms you could see could be wheezing, and this could be expiratory and inspiratory, or maybe even both. Sometimes they'll have cough, shortness of breath, intolerance to laying down. They have to sit up. Some kids will tripod, nasal flaring, accessory muscle use, things like that. And they'll not be able to speak in full sentences, very short clip sentences, as the same way with adults. And in this treatment, you want to utilize the same as we showed before, is the meter dose inhaler, nebulizer. In pediatrics, sometimes they'll use spacers to help deliver that medication more effectively. And sometimes in very in pediatric patients who have a lot of respiratory distress, you don't want to agitate them, as you know, sometimes they have a fear of strangers or EMS even. You want to utilize blow-by oxygen via mask and allow them to sit in a position of comfort, maybe in the lap of their parents, and just give them that blow-by oxygen as per their comfort. Additionally, you want to avoid any triggers as well, such as air pollutants, viral infections, allergens, cold air, sometimes even anxiety and dehydration can exacerbate or worsen an asthma condition. So now we're going to talk about COPD. And COPD is essentially an umbrella term for anything that's chronic obstruction of the airway. So you have emphysema and chronic bronchitis. So you'll have the pink puffers and the blue bloaters is what they usually call it. And these patients will have these chronic symptoms that can turn acute. You'll have chronic cough, sometimes productive with sputum, different colorations, maybe pink tinge indicate just, blood, or, yellow or green, maybe indicating infection. They'll have difficulty expelling air. They'll have wheezes and crackles, rhonchi, or even diminished breath sounds. They'll also utilize use of accessory muscles when breathing. So continuing on for oxygenation, for treatment for COPD. So these patients with COPD may have an altered level of consciousness, or even sometimes unresponsive due to hypoxia, because or also carbon dioxide retention. So these patients, you'll notice, will have difficulty laying down. So you want to sit them upright and elevate their head of the bed to effectively assist with ventilations and have them take that deep breath in. Sometimes you don't really want to hyperoxygenate the patient in a COPD patient. they have a different hypoxic drive, so maybe they may just tolerate 2 to 4 liters of oxygen rather than give that 15 liters. And you also want to assess a patient with their prescribed inhaler, also per med control. But often a patient with COPD will overuse an inhaler, so you want to watch out for any side effects that can occur as well. So just be mindful of that. Lastly, we're going to talk about evaluating an effective BVM ventilation. So this is an example of such. This is, however, a pediatric version. So I will show this in a manner that's still applicable to the adult size. So you want to place the apex above the bridge of the nose, and then the base is between the groove between the lower lip and then the chin. So essentially as such. And you want to kneel down to the patient's head and utilizing maneuvers to open their airway. You want to hold the mask with your thumbs over the top part and index over the bottom part. You want to grasp the lower jaw with the 3 fingers and make an airtight seal. This forms a C letter, so this is called the EC clamp method. So it'll be as such. So you want to deliver breath slowly and observe chest rise. You definitely also don't forget to attach this to oxygen, and usually at a rate of 15 liters per minute. So with a good seal around, you'll deliver essentially 100% oxygen, which is great. You want to deliver breath slowly and observe good chest rise. So you'll see color improving and the chest rise adequately, and this shows that you're providing adequate BVM ventilations. And of course, don't forget it's at 12 to 20 respirations per breaths per minute per adult, and essentially kids and infants are a little bit faster. And that concludes our respiratory concepts topic and skills. Thank you for tuning in, and have a great day. Hope you enjoyed.